Welcome to Raw Female,
a podcast that offers an unfiltered look at women in midlife.
We're your hosts, Kris
and Allie.
Hey, Al.
Hey, sister.
Hey, today's guest is Dr. Sara Tanza. She's a pelvic health physical therapist, and she's all about getting to the bottom of pelvic floor dysfunction.
Well, and her company is called Pelvic Potential.
Yep.
What I like about her is she's very into empowering women to be proactive about their pelvic health, which is something that I didn't know that much about.
Yeah, we learned a lot. Okay.
So let's talk to her.
Yep, on to our chat.
Hey, Sara.
We are so happy you're here, Dr. Sara.
I'm really interested in this whole pelvic floor thing. I think you're actually a little bit even more interested.
I'm super interested. Yeah. Anyway,
should we start at the top?
Let's start at the
whole
top.
thing?
Maybe you could start off by explaining what your pelvic floor is and then what kind of dysfunction it can have.
Yes. And first of all, thank you so much for having me on. Thank you so much for putting this podcast out. I've been listening and you are all equal parts hilarious and informative. And I think that's the best way to be educational. So it's really a pleasure to be here with you both. So the pelvic floor, it's like, it's very elusive because we all hear pelvic floor all the time, but what really is it, right? And so the pelvic floor, it's a group of muscles actually, and it's a lot of different muscles. So for example, you wouldn't just say the leg muscle, right? Even people who aren't in healthcare or sports, they would know you have quads, you have hamstrings, you have calf muscles. They all do slightly different things, right? So the pelvic floor muscles, they're similar. There are different muscles that compromise the bottom part of our body, okay? And the pelvic floor really is the bottom of our core. So we can think, our core everyone thinks about is just our abs, but really the top of our core is our diaphragm. Like if you picture a can of soup, the top of the can would be your diaphragm, your big breathing muscle. You have your abs that wrap all around and your deep back muscles. And then you have your pelvic floor muscles on the very bottom of the can. And those pelvic floor muscles, we have an outer kind of two layers that we can think of as like the closers. So we can think of like a circular muscle like around our anus that like closes our anus to like not let poop out, right? We have these itty bitty muscles around our urethra that close our urethra to not let pee out. We have muscles that loop around like vaginas and urethras and clitorises. The muscles that wrap around all three of those holes, if they get too tight, that could also not be so good if somebody wants to have penetrative sex, for example. Now, in the deep part of the pelvic floor, we have these deeper layers, and these muscles, they hold up all your organs, so they help prevent prolapse. But when those deep muscles get really tight, they can also be bad in like causing more constipation. They can cause pain with like deep sexual penetration. And if any of these muscles are weak, they could also lead to decreased core strength, which we know is a factor in things like back pain, all kinds of pain throughout the body. So they're very important and not really well understood. And then obviously we do have a lot of ligaments in there. We have ligaments that are also helping to support all of our organs. And then we have a bunch of nerves, right? Because pelvic pain conditions are a real thing. And so we can't forget all the nerves that are running through those structures as well.
Wow. So just hearing all that, you can tell that there's a lot of stuff that can actually go wrong or that can be dysfunctional.
Exactly. And like I was saying, there's muscles that are just towards the back with separate muscles towards the front. So maybe a lot of my patients in my practice, for example, they're having no trouble keeping poop inside their body, but they are leaking urine. So a lot of times in those patients, like the back half, their pelvic floor is functioning pretty well, but the front half, their pelvic floor, it's not functioning as well. So we can even have areas of the pelvic floor that are more functional than others too.
Once a person that has a vagina gets 50 plus, and maybe they've had kids, maybe they haven't, what have you seen some of the common issues?
Yeah, really good question. And I see a lot of people in that demographic. And so there's a bunch of different things. And so whether or not people have had children or not, we mentioned pelvic organ prolapse. And what that is it's when the organs that are in the pelvis, so think your bladder, think your uterus or your rectum, go into the walls of the vagina or go into like the rectum and the anal opening. And can present as a feeling of heaviness in any of those places. It can actually look or feel like things are falling out of either the vagina or the anal opening. So that's a really, really common thing. It's really common in people that have had a vaginal childbirth, but I've seen it in patients that have a history of C-sections in their past or patients that have had 0 children whatsoever. I also see it in patients with penises having rectal prolapse as well. So it's not something that's just limited to patients with vaginas as well. So that's one thing, super, super common. Leaking urine, leaking poop, both really common. And leaking, it can be 2 different kinds. It can be called stress incontinence. And so that's like leaking with things like jumping, coughing, sneezing, running, lifting weights. Or it can be urge incontinence. So that's like, I'm walking to the bathroom and I pee a little bit on the way, right? And another thing I see really, really commonly is people having pelvic pain. And you had what was the episode you had with the reproductive endocrinologist? And you talked a little bit about vaginal dryness. She was awesome. And so, pain with sex is a really common thing I'm seeing in my perimenopausal, my postmenopausal populations. But as well, I see that with, patients of all ages, right? But that's a really big thing that we can come back to at some point.
I actually didn't realize that painful intercourse was something that a pelvic health PT would tackle.
That's big time.
Yeah.
Big time.
Yeah, that's a great tip.
Yeah, that's something we'll cover today because I would say, okay. I would say maybe 20% of my patients are coming in for pelvic pain I would say 20% are coming in for even just that alone, like having pain with sex or pain with a tampon insertion or a medical exam of any kind. And that's the sole reason they're seeing me. There's a medical diagnosis for pain with sex. And so it's definitely something. And pelvic floor physical therapy is a frontline treatment for that.
Wow. Anything else that is common with people with vaginas in our age group that you're seeing?
And I would say that those are the most common things. Tailbone pain, because the tailbone, pelvic floor muscles connect to the tailbone for sure. And then sometimes other pain in the pelvis as well. But I would say incontinence, like leaking, prolapse, and then pain with sex are the really, really big ones.
But we have a friend who has been complaining of the whole having sex and it's painful. And she's never once said to me, hey, I have this and my doctor recommended I go to a pelvic health specialist. What's going on there? I'm 52. I've never once had a gynecologist say to me, you may want to visit a pelvic health specialist to work on, whatever. What's the connection there, or disconnect, I guess, is the better.
I think it's an emerging field for sure, even though it has been around for a while. I think people are becoming more and more, familiar with it, which is really, really awesome that there is something that you can do. And so, I think a lot of it sometimes is people are not even disclosing that information. So maybe they go to their doctor and there's so many other things going on, right, that they're talking about, and they might not even think that their doctor can help them. Right. And so I think now we're starting to talk about it more, and, shows like your all show is really getting the word out that there are more treatment options available. Right. I think a lot of times, unfortunately, people have gotten advice like just have a glass of wine and relax, or just use extra lube. And, I love wine. I love lube. Those are all great things. But there are other things we can do on top of that. And so let's, even if we can get right into even the painful sex thing right now, a big thing is that, let's say somebody is postmenopausal, they're having, dryness that is starting to increase, right? Let's just say this person has never had painful sex in their life, or a really common thing is this patient, they had painful sex after childbirth. Let's just say this person had a child. This is a presentation I see a lot, but then it goes away. Maybe it was painful for the first year, goes away. Now it's however many years later, they're going through menopause and it reemerges again. Okay. So what does that person do? They're like a little bit dry. They go talk to their amazing reproductive endocrinologist or doctor. Maybe they, get some vaginal estrogen or whatever, or they start using lube. And they have the whole lubrication thing is a little bit more under control. But guess what has happened? they were possibly having penetrative sex for months, years, whatever. And the friction that was created during that penetrative sex, whether it's with a sex toy, penis, doesn't matter, whatever they're using, the body felt that friction. And even though it was, at first it wasn't as bad, it got worse and worse and worse. And guess what happened? The muscles started getting really, really, really tight. Okay. And so now that patient has better lubrication, right? Either all the time because they are starting some type of an estrogen situation, or because they're just using lube. But the brain has not forgotten. And so it's almost like the brain has this post-traumatic stress response where even though the lubricant's there, the muscles have now gotten in this habit of being in spasm. And so that's where really pelvic floor physical therapy can come in. Just like if you're coming to a, quote, normal physical therapist because you have, really tight hips and they help work on those muscles, we can work on the pelvic floor muscles as well to then get that going along with all the really great things you're already doing with your doctors.
I learned more in that one sentence than I've ever learned in my 52 years of like asking questions of my gynecologist.
I know it's super interesting. And maybe we're rabbit holing too far, but I'm just going to throw it out.
Our audience loves the rabbit hole.
I'm detail driven and I want to know what does, what kind of exercises do you put that person through?
Yes.
And Kris wants to do them while we're on air. No. Just FYI.
I love it.
Somebody who's like, you're saying it's a muscle tightening thing.
Mm-hmm.
They come into you. What does that look like? What would that look like?
Yeah. So, first of all, we can zoom out a little bit because that's literally what I do with my patients, right? I don't just look at just the pelvic floor because your body is way bigger than that, right? And so how you're moving throughout the day, maybe you're always clenching your butt. I always ask people like where they feel stress in their bodies. And a lot of my patients, they feel stress literally in their anal opening, right? Like we joke like, oh, you're so anal or whatever, but a lot of times people really are. They're always clenching there, right? And so we kind of see in common movement patterns is that person just clenching their butt all the time. That's probably going to drive some more pelvic floor muscle tightness. Are they sitting and squeezing their legs together all the time, right? A lot of times what we're doing with our inner thighs also is, reflected in the pelvic floor. Are they sucking their belly in all the time?
I was just going to ask you that because that's a huge yes.
Do you do that?
Me? No.
No. Okay.
Oh God, no. But I know a lot of
your
women.
Belly in. Okay.
They want that flat belly.
Yeah. Okay. That makes sense.
Thing.
That makes sense.
Yeah.
But think about it, like this whole flat belly thing. it's almost so old school because like if you kept your core tight all the time, that's the same thing as if you kept your quad, your quadricep muscle and your leg locked out all the time. You wouldn't walk normally. You'd walk like on a straight leg, right? Like your abs, they should come on and off. They shouldn't just be clenched. Otherwise, you actually can't stretch. I'm like reaching my hand over my head if my abs are really clenched and tight, right? And so it shouldn't be held tight. So I know I listen to podcasts a lot when I'm driving. So if you are driving or if you are like, at home just relaxing, even check out right now, can you let go of your low belly? Can you let go of your anal opening? Can you let go of your inner thighs? And a lot of times these patients that are having, painful sex or just like, pain in their pelvic floor in general, sometimes they're clenching in one of those areas. And a lot of times that can actually help. So that's one thing that I would check is any postural holding patterns.
Okay. You know what's really interesting about that? When you go to the dentist, they actually ask you if you're clenching because I'm a clencher in my teeth. I just find it super fascinating from the waist below. These questions are not being asked.
I know. It's
like, it's almost like the belly button below. We're not going to talk about that. You talk about that in the privacy of your gyno office. It's like, we need to now. No, I'm done with that. That's why we're doing this podcast, by the way, because we're like so done with not having these as normal conversations. Exactly.
And when you come to your local pelvic floor physical therapist or see us virtually online, there is no question off limits. Basically, everybody starts their thing with this might be TMI. I'm like, oh no, bring on the TMI. It's always from me, like, we can get to the heart of what's really going on with you, you know? Yeah. So it's really important.
Right.
So yeah, so the postural holding patterns are big. And then also thinking of like watching someone like squat down, like, is someone, you know, able to use their legs, right? Because a lot of times, let's just say, you know, even we can get into prolapse later, but like when people aren't using their leg muscles, they might have forces being put onto their pelvic floor, right? That shouldn't be going there. So we look at a lot of things besides just like the pelvic floor, but specifically, like your question is, how are we getting your pelvic floor muscles to learn how to like relax and soften? So, you know, just like your other pelvic floor or your other regular physical therapist, let's just say for that are working on your hip or your back, we might do actual like muscle relaxation techniques, like using our hands, right? So we do intervaginal, interrectal treatment, obviously with gloves, obviously with lubricant, obviously with tons of consent, and talking to our patients about the entire process and educating them about what's happening, right? But even doing specific little, you know, mobilization techniques for muscles, the same way someone might work on your hip muscles. So we do manual work that way. We do adjustments of the pelvic bones, because sometimes if the pelvic bones are really thrown off, right, and there might be an alignment issue that could be pulling on the pelvic floor muscles and causing pain. We do like scar tissue work, because even somebody, they had an episiotomy however many years ago, 20 years ago, they might still have pain as a result of that old episiotomy scar. So just like if you had a scar in your knee, we treat your scar, right? Same idea. And then we do a lot of work connecting the pelvic floor with the breath. And maybe we can even do a little bit of that today with your listeners so they can play with that and see.
That would be super helpful.
Okay, so for those people that are having painful sex right now, what takeaways or either exercises they can do at home? What is your feedback loop to them right now?
They can totally do a couple things here. So the first thing is, I'll just back up to a little bit more of the anatomy of the pelvic floor muscles. Now, we all learned it's a lot of muscles, right, at the bottom of our pelvis. Remember I said the diaphragm was on the top of the core? Guess what? The diaphragm and the pelvic floor, they should move together. So when we inhale, breathing 101, our diaphragm muscle that's under our lungs, it drops down. It pulls our lungs open to create a vacuum to get air into our body, right? And then when we breathe out, it rises back up. The pelvic floor should go along with that. It should be able to open and soften on the inhale, and then it should recede back up on the exhale. So for these people who are having painful sex, one of the first things I have them get into is what we call like pelvic floor breathing, which is first like kind of normal diaphragmatic breathing you might do in a yoga class of putting a hand on your chest. And you can do this if you're at home. If you're driving, be careful, maybe pull over, or wait till you can go home and lay with your legs up on a chair. Hand on your chest, hand on your belly. And first see, can I breathe into my belly without having my chest move up and down? That is hard for a lot of people, okay? Once you can get yourself to breathe into your belly, your low belly, then can you take a finger and put it either inside a vaginal opening or next to vaginal opening? Or if you're listening and you don't have a vagina, you can put it next to your anal opening and see if you can start to feel a little bit of movement down in your pelvic floor with every breath. And what you should start to feel, this might take you today or maybe a month from now practicing this, you might feel a slight swelling into your finger on the inhale, and then a gentle receding back on the exhale. So diaphragmatic breathing, letting the diaphragm show the pelvic floor how to relax in the sequence it could when we were babies, before we sat and did all the funky holding patterns that gave us pelvic floor dysfunction. So pelvic floor breathing, that's the number one thing I recommend for painful sex. And then two other things would be taking a finger and inserting it into the vagina and finding a place maybe in the vagina where you're having a little bit of pain. A lot of people, let's just say it is that old episiotomy scar site, right? Or another tender area, putting a finger there and then doing the breathing with your finger in that position, not trying to like excessively stretch that area, but just almost giving it a little bit of gentle feedback saying, hey girl, do you really want to be as tight as you are right now? And seeing if just that little tactile cue can help the brain start to let go. You mentioned the jaw tightness with your dentist. Actually, the jaw is really connected to the pelvic floor, right? So think of people who've had babies, think if they tell you, like open, make big, like, low vocal sounds, let the back of your throat open. So a lot of my patients, I'm treating them vaginally and I'm asking them, hey, do you clench your teeth at night? And they're like, oh yeah, big time. And then I say, relax your jaw. And I feel a vice that's around my finger, aka their vagina squeezing me because they're so tight, start to let go. So if you're listening to this, you could even think with the breathing of trying to let your jaw go. And so that can be something. And then there's actually something called vaginal dilators. So this is something you could Google it. I like the Intimate Rose brand, makes some really nice ones. And they are actually these little objects. It almost looks like a silicone tampon. They make them in plastic, all different kinds, right? And they start really itty bitty, right? Like a pencil. And they go up to big, scary sizes and everything in between. And you literally can, I don't show my patients that are having painful sex the big ones. I say, look, you can start with this one. It's fine. And you can actually practice inserting them, getting bigger and bigger until it is the size you desire, being able to tolerate, inserting them, taking them out, moving them around, and not like forcing them in, but just kind of in the manner we just talked about, touching an area, letting it soften, and just practicing. So I would say pelvic floor breathing, doing some targeted relaxation, touching a certain area, and then possibly using dilators. And all of this is, with the idea that they're also having sexual penetration take place with lots of lubricant, both on the outside of their body, putting it deep inside their body, and then putting it on sex toy, penis, whatever, just so it's not like a squeegee of when it comes in. Because I see people putting it just on, they're a hero about people putting it on sex toys, penises, and not on their own body at all, or just on the outside. And then once it goes inside, there's kind of no lubricant there to meet it. You know what I mean?
Great tip.
These are
great takeaways.
We're big on the takeaways.
Dr. Sara, queen of takeaways.
Because I think as you get older, it's like, okay, can we just skip to the end and tell me what is going on here? Because I think there's a lot of dancing around stuff, like, again, below the belly button. Okay, so
but let's talk about the incontinence.
I was just going to say incontinence. Right. Let's move into that.
And the two types,
a little
the
bit.
urge and the stress.
Yeah. And it's so funny because I have a lot of patients that say, okay, well, I'm having painful sex. That means I'm too tight, but then I'm also leaking pee. So that am I too loose? And they're just confused because they're like, how do I have like, quote, a tightness problem and a quote, looseness problem? And what I tell them is that like the pelvic floor, it should kind of be like a jellyfish, right? So I'm in Santa Cruz, right? We're in the Monterey Bay with all the jellyfish swimming around. So you can't see me obviously, but I'm making a motion with my hand like a swimming jellyfish. And so the jellyfish should fully open, right? That's like having pain-free sex, but then it should fully close. So like stopping the pee, right? But a lot of my patients, they're somewhere in between. So I call it like the dying jellyfish where they're not fully opening, not fully closing. They're just like, so you're not you're getting kind of problems in both ends. And so actually for people who are having urinary incontinence, I would say in my practice, 9 times out of 10, I still need to teach them how to relax their pelvic floor to some capacity. Either, in general, they're starting at a kind of more tense state, or if they're trying to, quote, do Kegels, which we can kind of break down a little bit, are they fully actually relaxing in between, or are they doing this kind of like mini half Kegel without a full relaxation? So that happens a lot for incontinence. And so we can just talk about like that, stress incontinence first, right? People who don't have their pelvic floor muscles kicking on the way they should. A really big thing with that, and I'm simplifying, obviously, I really, this is the caveat that I want everyone to visit a pelvic floor physical therapist. And I do think that, everyone should see one if you can before you're going to go through menopause or during or after. There's really no time that's ever too late. So obviously this is not tailored to one specific person. This is really general information. But the idea, do we have pelvic floor muscles in the front near the urethra contracting as well as the ones in the back near the anus? Because a lot of times I bring my finger up towards the front of somebody's, vaginal opening near the urethra, and I have them try to contract those muscles, and it's like crickets. I'm like, no, I said to contract. And they say, I'm trying, right? And I don't feel a lot of muscles firing. And so what you could even do if that is you and you are having some leaking towards the front, first seeing, can I even get that relaxation, that pelvic floor breathing? Can I breathe down and let my pelvic floor muscles go? And then remember how I said that like our pelvic floor muscles should kind of close and rise as I exhale, as I breathe out, like I'm blowing up birthday candles. That's when they should, right? Can you try to breathe out, exhale, right? And at the same time, close and lift through your pelvic floor muscles, and do that with, quote, the entire vagina. See how well you can do that on an exhale. So those of you who are trying at home, you can see, and you can even put a finger inside your vagina.
Yeah, why do I feel like my sister who's sitting next to me is doing those right now?
You have to. Oh, you do? Yeah. If you're at home, put your finger inside your vagina. Again, don't do this in your car. Don't do this at work. Do this with your sister in the podcast recording. But put your finger inside and try it when you're laying on your back. Because even like you're all sitting right now, but it might be a little bit easier or harder if you're laying on your back to try. If you're standing, if you're going for a run or walk, do not do this. I don't want my patients running or walking, closing and lifting through their pelvic floor. That's a big no-no. We can get to that. Even if you leak when you run, don't just run with a clenched pelvic floor. It's not going to work. Not going to work in your favor. But even put your finger inside and feel. You can actually feel inside. Can I close my pelvic floor muscles? Can I close my vaginal opening, let's just say? And then can I lift? And then can I go back down and let go? Right? So that's what we talked about. You should be able to do all of those things. Can I first start in a relaxed state? Right? And then can I breathe out? Can I blow up the birthday candles as I close and lift? And then can I inhale and feel my pelvic floor muscles relax? It's a really big one of those pat your belly, rub your head moments, right? To just coordinate that. And then if it wasn't hard enough, we could then say, okay, now move your finger up towards the front half of your vagina, like closer to your, the front top part where your urethra is. And then can I do that same thing, really focusing on the muscles surrounding the urethra in the front? And in a lot of my patients who have urinary leakage, a lot of times when they try to focus it on the front muscles, they can't really get those muscles to activate as well. So the first step is cluing the brain into that there are muscles in the front that could, maybe need a little bit of a tune-up.
Right? How much of this is stress related versus like physical? Like, I'm sure it's hard to untangle that, but I have to ask because we're in COVID.
Such a good question.
You must be getting a lot of calls because I feel clenchy during COVID. My sister, by the way, is like at a spa. Every time I look at her, she looks like she's at a spa because she doesn't have kids in the house.
Oh my gosh.
You don't have kids in the house. But I feel like my whole body is one big clench. So I'm wondering what the connection is with stress.
Is there one?
Oh, yeah. Is there? Big time. Yeah. Because like when we're more stressed a lot of times, and this is just even people before COVID, just people with anxiety. And so I just say, everybody is at a low level of anxiety now, or most people. A lot of people are breathing more up in their chest all the time. And so remember I said like with good diaphragmatic breathing, we get that nice relationship with our pelvic floor and diaphragm dancing, right? But if I'm breathing up in my chest all the time, I'm not normally getting in that same rhythm of the pelvic floor and diaphragm moving together. So it's kind of like, I'm breathing up in my chest and my pelvic floor is just kind of clenched down below, right? And so those people are more in that dying jellyfish state where maybe they're having more pain with sex and then also more urinary incontinence. So I don't think you're off at all.
And it sounds connected to a breath work. This is another thing that I'm totally shocked about.
It is. And like I said, and the breathe, and that becomes like a superpower to help you to strengthen your pelvic floor is like knowing that relationship, that it's going to be stronger to do a quote Kegel when you're also breathing out. It can help you kind of strengthen it. It's like a little, supercharged power for that area. And then also stress can be really related to that, urge incontinence, that thing of I'm walking to the bathroom when I have to pee, or like, we in pelvic floor physical therapy, we joke about this. We call it like the key in the door leaking, right? Because like get home from the grocery store, you put the key in the door and you feel like you have to pee right then. And so that kind of incontinence is super linked to stress. And the cool thing is we can actually change it really fast by even having people notice that like the first thing they do when they feel that urge come on is to start to calm themselves down, to start to breathe a little bit slower, to start to say things like, I'm in complete control, relax their body, resist the urge to run to the bathroom and instead walk to the bathroom. Anything that tells the body you're okay and you're safe, because you can tell if you get in that fight or flight response, that's like the dog that gets scared and just pees, right? And so we want to get ourselves out of the dog that's scared mode and do the dog that's just, all chill and work with our nervous system that way. And that's, in my opinion, that's been one of the best ways I've been able to help people work through their urge incontinence.
Right.
Kris, are you having any of those issues?
I have a question on the fecal incontinence.
Well, that's where did you see my face? I was like, I know. Kris, I led the witness on that one a little bit because I've been with you when you're like, I have to use the bathroom, which means I have to use the bathroom in
5,
4,
right,
3, 2, 1, and we gotta get her to a bathroom.
And I can't quite figure out what's going on here. And I mean, this is all about destigmatizing these conversations. So I'm going to say, number one, I'm a late in life coffee drinker. So I don't know if this is a thing. Number two, I don't like, not that people love to spend time in the bathroom. I don't understand why and now I'm going to be super stereotypical.
I know, but I know where
what is it with these men that love to like be in the bathroom for a long time? No, I am totally okay. Hate mail, bring it on. But I'm like in and out.
Okay. So then like the question for me is, am I having a control issue or
fecal urgency? You could say urgency.
But I feel like, it's definitely something I'm mindful of.
Yes. So really good question. Yeah. And that's related to your nervous system for sure. So sometimes, first of all, if you just are getting a little bit more anxious in any minute, that could cause just more like GI upset, which could make you have to have a bowel movement. But also it could be the same thing. So maybe you guys are, on a walk or, I've had this even with my kids, my 5-year-old even, and he's like, I need to poop right now. And I say, okay, buddy, it's the same thing I would tell you all. I say, okay, buddy, it's okay. Tell your body I'm in control. Let's take some deep breath. Let's slow our body. And even doing that a little bit can help. Obviously, there can be lots of GI stuff linked to what you ate, right? Maybe having a little bit too much coffee, things like that. But that is something. And so a lot of times that same thing of working with the nervous system and doing the whole I'm in control, I'm going to move slowly, I'm okay. That can also really, really help, taking the slow breaths. And the more you get yourself in a panic, the more it's going to want to come out, especially if you're squeezing your belly tight, because that's just going to put downward pressure.
Are you doing any, do you do like an assessment, a food assessment? Because I've noticed it's pretty much when you eat pie.
Kris, I eat pie? How often do I eat pie?
I mean, it'd be
on.
Yes. Pie and dessert. And then she has to go to the bathroom immediately.
So how much is fecal urgency related to what you're ingesting?
Well, actually, I mean, like what you were just saying could also be used for the urinary urgency, or I'll talk about urinary frequency in a second too. We have patients fill out something called like a bowel bladder diary, right? Which is hilarious to say, but even having them track their food and, food and beverage intake for a couple days up to a week, and also tracking their output and their urgency, right? So we can see like all the things they drank throughout that week. And then, at 8:00, peed, small amount, pooped, large, whatever it was, urgency present, yes or no. And then, for example, I mean, one thing we didn't discuss, I should have brought up earlier, was urinary frequency is a big thing with patients, right? So you all have the friend that has to stop for like 25 times on the road trip, right? And really what we found is that people, for the most part, should be able to wait about 2 hours in between peeing. But a lot of times that's not happening. It's that person who's peeing every 30 minutes, especially now with work from home and with like not as much availability of bathrooms. So people are trying to like always pee before they leave, even if they don't really have to pee. And so through something like a bowel bladder diary, they first can see, are there any, relationships between like a food or a beverage trigger and having more, like you said, urgency, fecal or urinary. Or as they track it throughout the day, they can see, oh my gosh, I'm actually peeing so many times throughout the day, and it's only a very small amount of urine, right? So then we can go back through and say, hey, look, you didn't pee very much at all these times. Maybe you could, eliminate this one bathroom trip. Or, hey, this whole week we noticed that you had more fecal urgency whenever you ate blank. Let's try not eating that for a week and see how you do. So it's really helpful to kind of zoom out sometimes and see what factors those could be. And it's a lot of it's just helping patients investigate their own life. I also refer out to other providers as well that might be a little bit more specialized once it's something that, I can't help them with as well.
Join us next week when Dr. Sara explains what happens in a diagnostic pelvic floor exam. She also does a deep dive on prolapse and tells us when we should see a pelvic floor physical therapist. Until then, follow us on Instagram at Raw Female Podcast and join our email list at rawfemale.com.